topic before you. I sincerely regret I was not able to come over there because of my health issues. Even then, he allowed me to do it in the online platform. Anyway, special thanks to Dr. Balkrisna. I hope in this online platform, after I heavily and it is difficult to concentrate. Even then, I request all of you to go through the slides and try to understand what I am sharing. Okay. So the content of my presentation is brief anatomy and physiology of deafness of ear and the types of hearing loss and overview, how to approach the diagnostic measures and sensory neural hearing loss, pathophysiology, advanced neuroimaging, electrophysiologic investigations, molecular and cellular investigations, genetic investigations, clinical management protocols, and then finally conclusion. This sensory neural hearing loss, this department requested me to concentrate on sensory neural hearing loss. Since this conductive hearing loss is discussed in other sessions, so I am concentrating on, after the introduction, I am concentrating on the sensory neural hearing loss. Am I audible? Yes. Okay. So coming to a brief anatomy of the auditory system, you might have heard about this anatomy in the previous session. Only one slide presentation, just to refresh your thinking about this ear. This external ear, middle ear, and internal ear. External ear consisting of thin and external ossicles canal. In the middle ear, tympanic membrane, the ossicular chain including malleus, incus, and states, and the middle ear spaces connecting to this eustachian, connecting by the eustachian tube, and the inner ear, cochlea, vestibular system, and the neural pathways, consisting of our auditory nerve or vestibulocochlear. Physiology, I am planning to do it in
begins with the external ear funneling sound waves through the external auditory canal to the tympanic membrane. The tympanic membrane vibrates in response to the sound waves. Three connected bones, called the malleus, incus, and stapes, transmit the vibrations through the middle ear. Movement of the stapes causes vibrations of the membranous oval window of the inner ear. Oval window vibrations create fluid waves in the two perilymph film chambers in the cochlea, ending at the round window. These waves of perilymph also push on a third fluid film chamber called the cochlear duct. Inside the cochlear duct, sensory receptor cells, called hair cells, line one of the walls of the duct, called the basilar membrane. The tectorial membrane covers the hair cells. Collectively, this group of structures is called the organ of Cordy. Fluid pressure in the perilymph pushes on the basilar membrane and its attached hair cells, which bend when pushed against the stationary tectorial membrane. This event sets off a chain reaction within the hair cells, converting the pressure wave to a nerve impulse in the nerve fibers. Nerve fibers throughout the cochlea combine to form the cochlear branch of the vestibulocochlear or auditory nerve, which transmits the sound nerve impulse to the brain.
I think a lot of explanations is not, this type of video is more effective than a lot of explanation of physiology. I like this type of videos, that's why I shared one. Hope you also like this type of animated physiology. Hope so. Now this sound transmission through the external ear, leading to the middle ear transformer mechanism and the inner ear fluid dynamics and the hair cell functions as we see, and finally come to the neural pathways and the cortical processing and the we feel that we heard that sound. That is the connection of the physiology. Coming to the types of hearing loss, it is classified based on anatomy, age of onset, and severity. On the base of anatomy, it is divided into three: conductive, sensory neural, and mixed. This conductive means it is due to the errors in conduction of sound waves. Sensory neural due to the neuronal damage from the inner ear to brain. And mixed is both at a time, both conductive and sensory neural hearing loss will be present. Age of onset, congenital from birth itself, or maybe acute. Severity of this hearing loss, it may be mild, moderate, or severe or profound. If it is the loss is if you are doing audiogram, if it is 26 to 40 dB, it is considered mild, 41 to 60 it is moderate, 61 to 80 it is severe, and beyond 81 it is considered as profound hearing loss. The pathophysiology of conductive hearing loss, main causes are wax impaction. In majority of cases, we can see the wax impaction as the most common cause. Then infection of the middle ear or otitis media, ossicular discontinuity. Due to any degenerative changes, there may be discontinuity of the ossicular chain. Then otosclerosis. Then this sclerosis of the manizingous of states. Coming to the mechanisms, that may be due to sound wave obstruction. This transmission of sound wave may be obstructed at any point, leading to a loss of hearing. That is included under the conductive hearing loss. Ossicular chain disruption, as I told earlier, and middle ear pathology, otitis media or ossicular discontinuity may be the mechanism. Then diagnostic features, airborne gap. That is, while doing this audiogram, we can see the graph. In the graph, there is no gapping. There is a gap in air conduction and bone conduction. It is called an airborne gap. While we are doing this Rinne's test, this air conduction will be abnormal, but normal bone conduction will be normal. This Rinne's test audiogram extra will be covered in a session. I don't know when it is over or not, but it is there in another session. About the symptoms of this hearing, along with the hearing loss, there may be vertigo, tinnitus, discharge, etc. That also we have to see. There is infection, there will be this discharge, etc. Coming to sensory neural hearing loss, common causes are age related. As age advances, there will be degenerative changes in neuronal tissue also, leading to this hearing loss. Noise induced. If this person is the working condition of the person is in a highly noisy atmosphere, there is chance of noise induced hearing loss. Then ototoxicity. Ototoxicity drugs. Even aspirin is considered as ototoxic. In other antibiotics like streptomycin, tuberculosis drugs, cancer drugs, etc., can cause ototoxicity and finally hearing loss. Genetic factors. There are familial loss of hearing losses can also be seen. So genetic factors are having influence in sensory neural hearing loss. Coming to the cochlear dysfunction, there will be dysfunction of the cochlea in this generating the sound waves, transforming the sound waves into electrical signals. Neural pathway disorders from the cochlea through the auditory nerve and the brainstem, then to the brain through brain areas like temporal, parietal, and frontal areas. In anywhere in this disorder, in any disorders in this pathway, will also lead to hearing loss. Then central processing issues in this temporal, parietal, and frontal lobes. If there is any pathology, may lead to hearing loss. That's diagnostic features. No airborne gap. This when we are plotting the graph, this air conduction and bone conduction go together. That is called in audiogram. It is called as no airborne gap. Bone conduction is affected. Why? Because when the bone conduction test then the release is done, even though bone sound waves are conducted through bone up to this cochlea, Due to this neuronal damage, it cannot be processed. So bone conduction is also affected in sensory neural hearing loss. Associated symptoms as tinnitus, and vertigo, etc. can also be seen. These associated disease symptoms can also be seen here. Coming to the mixed hearing loss, this definition combined conductive and sensory neural component. This both will be there in mixed hearing loss. Pathology may be multiple. Even this metabolic syndrome, this thyroid function problems, hypertension, etc. can be lead to this mixed type of hearing loss. Pathophysiology, interaction of mechanism will be there. This metabolic disease can lead to this type of hearing loss. Complex presentation because it is both conductive and sensory neural nature. So the presentations will be very complex. So diagnosis will also be very difficult. Investigation, a lot of the investigation we have to do to come to a conclusion regarding the hearing loss. How to diagnose a person with the hearing loss? First, history is important. The person can't convey more ideas. This bystander have to help the patient. Then multidisciplinary clinical assessment. Multiple departments must involve in the assessment. Why? Because not only this ENT surgeon can do that. This neurologist, etc., have to do their duty. Even then, this metabolic conditions are underlying is having this underlying cause. These metabolic doctors can also have to. Endocrine doctors may also have a role in this deafness. Then advanced diagnostic image. A lot of diagnostic images are now available. They must be utilized for precise diagnosis of the condition. Specialized neurological and audiological testing. This neurological testing we will discuss in the later part of this presentation. Then genetic and molecular investigation. Since this deafness is having genetic predisposition, genetic and molecular investigations. This presentation of protein, genes, which gene is affected, we can have to identify that, and molecular investigations in cellular level also we have to see whether there is a mitochondrial difference or any protein difference, RNA difference like that we have to investigate. So it is molecular investigation is also important in a case of deafness. Approach, am I audible? Approach to a patient with a hearing loss. Structured, systematic approach is crucial for accurate diagnosis. Step by step, we have to approach the patient. Initially, if there is any conductive problem, in the external auditory matrix, if there is any problem, if there is any tympanic membrane problem, like that, step by step, we have to approach the patient. Initial classification into conductive versus sensory neural hearing loss, as we told earlier. Then timing, sudden as well as gradual onset. Sudden onset in trauma, this viral infection or autoimmune diseases will be sudden onset of deafness we can see. In gradual onset in aging and this metabolic disorder, this onset will be gradual only. Document unilateral, bilateral involvement. Then note associated symptoms like tinnitus. Tinnitus is ringing in the ears, vertigo, ear pain, discharge, etc. And screen for systematic hearing. Systemic conditions affecting hearing. Coming to history taking, begin with open-ended question. No yes or no questions. We have to ask the patient to describe the conditions. Then document precise onset and progression pattern. It is very important how the disease started and then how it was progressing. That they have to explain to identify whether there is any underlying causes. We have to look into it. Quantify impact on daily activities and quality of life. So this quality of life of the patient will surely become down because of this deafness. They cannot communicate with others. They cannot understand what others are saying. So there will be a chance of depression, and so we have to address that also in some cases. Record previous hearing evaluations and interventions. In majority of cases, they will go for multiple system for the treatment, and we have to record all these previous evaluations and treatments. current medications, especially ototoxic drugs. In cancer patient, etc., they are taking this chemotherapy, there are chances of this hearing loss. So it also be recorded. Assess communication needs in work for social environment. In majority of cases, aged persons will be the patients. So their social and work environment we have to ask for better understanding of the condition. Document any hearing or assisted device usage. So red flags in history taking. Sudden hearing loss. Within 72 hours, if it is unilateral or no apparent cause. That may be due to viral infection or autoimmune flaring of autoimmune condition. There may be sudden hearing loss. Then coming to the neurological symptoms, facial paralysis, especially Bell's palsy, severe vertigo, persistent headache as in hemorrhagic conditions. Visual symptoms should also be taken into care. Systemic condition, head trauma, meningitis, autoimmune disease flare, and post-chemotherapy may be inquired into. Occupational concerns about acute noise trauma, then chemical exposure, and narrow trauma. This is a pressure difference, exposure to pressure difference areas. Coming to detailed family history, genetic patterns must be inquired into. Age of onset in family members, because this deafness is seen in families, pattern of inheritance, syndromic features and syndromes. Some syndromes are new or even where this deafness is a main symptom. Family pedigree, we have to prepare 3-generation chart at the age of onset of each generation and if there is any associated conditions. Then coming to consanguinity of marriage, relationship of parents, there is any parents are related, there is a chance of these genetic diseases. Then community practice, in some communities, these relatives must only be get married. In such communities, this deafness may be high. And genetic counseling, in such condition, we have to go for counseling to avoid such genetic diseases. Then associated conditions, syndromic features, we will discuss later, and system involvement. Which systems are involved, or not only this ear and this associated structures, but whole system can be included as metabolic diseases. Cardiovascular can sometimes be an underlying, cardiovascular disease can be an underlying cause. Even anemia can become an underlying cause of deafness. And then development patterns, how this leads to deafness that we have to inquire into. Occupational history, noise exposure. High noise in the atmosphere where noise is high and gradually lead to deafness, and chemical exposure. Ototoxic substances can lead to this finally deafness. Audiometry we have to do before for complete documentation of the condition, and regularly we have to monitor whether it is worsening or not. I think without Ayurveda we can do Ayurvedic treatment. Even though there is initial stages of deafness, we can improve the condition with the Ayurvedic treatment. It is proven. Preventive measures, personal protection from workplace modification, and regular screening are essential to prevent this deafness. For physical examination, there should be a good room with a quiet environment, proper lighting, and essential equipments for examination of the patient. Patient must be positioned at the level of the examiner itself. Equipments require an otoscope with square bulbs, tuning forks, head mirror or light, and axe removal tools. Majority may be having earbags, so it must be removed, then only we can see the tympanic membrane, etc. Then documentation materials, examination charts, digital imaging capability, and recording notes must be there in the examination room. Infection, this hand hygiene, etc. more important after the cold condition, etc. Then systematic head and neck examination must be done. External ear for pinna and pre and post auricular region in front of the ear and back of the ear must be looked into. And the tenderness in the mastoid process must be examined. facial nerve, since this facial nerve is closely associated with this deafness, it must be examined. Like there is a Bell's palsy, it must be assessed, and there is any associated findings that will be recovered. Other cranial nerves, including this trigeminal, etc., must also be examined to see whether there is any connection. Then coordination test must be done, because in majority of the deaf cases, due to this semicircular canal problem, there will be vertigo also. Vertigo and balance problems will be there. So we have to examine this coordination test, including this hearing test, etc., to exclude the presence of cerebellar lesions. Balance also must be assessed, that we will discuss later. Coming to the neck examination, lymph nodes must be examined to see whether there is any this cancer or adenopathy, etc. Thyroid must be examined, and if there is an arterial growth, that must also be looked into. Physical examination protocols, otoscopic evaluation, neurological examination, and cranial nerve assessment must be done. Otoscope, this is the otoscope. Patient must be positioned at the level of the examiner, head tilted, and must be properly lightened. Technique gentle, must be gentle. The spinner must be stretched backwards and properly with the gentle pressure. Speculum size must be proper. You can see that the light must directly fall into the tympanic membrane itself. External canal, after external canal straightening, you have to look into the external auditory meatus. Common mistakes, speculums must be proper, lighting may not be adequate, and handling. Sometimes small children will be coming, but handling must be very, very gentle, and the visualization must be complete. This is the findings, common otoscopy finding. You can see that this lateral prosomalus can be seen. So there is some inflammation. Common flight can be seen at the center part, and this ossicular landmarks. This lateral prosomalus can be seen. Past tensile this part, and the placid portion, past placid can also be visualized. Pathological findings: external canal, wax impaction. Foreign body, sometimes the children may do foreign bodies in the external auditory meatus, that also have to be looked into. Ear infection, external ear infections are common, that must be addressed, and tympanic membrane for perforation, retractions or effusions must be seen. Maybe then coming to the audiological assessment, pure tone audiometry, speech audiometry, impedance audiometry, and auditory processing evaluation. These are very important areas. They will be discussed in detail in other sessions, so I'm skipping that area and coming to the sensory neural hearing loss. This is the portion which I am planning to elaborate. The specialized clinical assessments include vestibular function testing, balance mechanism evaluation, cognitive screening, and communication skill assessment. I think rather than explaining a lot about the testing procedures, videos will be giving better results. So I have included a lot of videos in this presentation. Hope you can understand that. Vestibular function testing, they includes calorie testing, rotational chair assessment, and computerized dynamic posterography, and vestibular evoked myogenic potential of VEMP are coming under the vestibular function testing. The caloric test evaluate the function of horizontal semicircular canal and vestibulo-ocular reflex by irrigating the ear with a warm or cold water or air. This is to identify the function of semicircular canal and vestibulo-ocular reflex. Normal response, there will be nystagmus. I think you are remembering the nystagmus, this fluctuating type of movement of the eyes, and then faster phase of nystagmus is towards the stimulator's ear, and this is a cold phase with the warm water or air. If cold water or air is used, faster phase away from the simulated air. There is a mnemonic house, that is cold opposite, that is towards the faster phase towards the opposite side. Warm same, in the warm is used towards the same, faster phase of the nystagmus is towards the same side. Abnormal findings includes hypoactive response. that is reduced or absent nystagmus may be due to vestibular neuritis. Hyperactive response, exaggerated nystagmus may indicate central issues. Directional preponderance, asymmetry suggests unilateral dysfunction. Bilateral weakness, absent response in both ears suggests bilateral vestibular loss. Clinical use, diagnosing vertigo, dizziness, Meniere's disease, or vestibular neuritis. And please see the
One
video.
test that people are aware of, and that is most commonly done, is called the caloric test. This test has been around for over 100 years and is considered to be the gold standard for vestibular testing. When we're getting ready for this test, the patient is reclined back into a 30-degree position. Sarah's going to be in the dark, but her eyes have to remain open. We're going to use air to irrigate the ears. That means we're going to change the temperature of your ears. The inner ears are filled with fluid. So changing the temperature allows us to create a bit of a convection current, which tricks the ears into thinking that you're moving. When the ears think you're moving, we get a reflex that we can record through our goggles. That reflex is called nystagmus. From there, you may also feel like you're moving. Some people don't feel much of anything. Others may feel like they're rocking or on a boat. Other people do feel like you're turning or spinning. Any of that is completely normal. I'm causing it. I need for that to happen. So let's take a look at what this response looks like and how it's done. We'll be doing a test on Sarah's left ear using warm air. The air goes into the ear for 1 minute, and during that minute, she may start to feel a sense of dizziness. During that time, we may also start to see some eye movements or nystagmus on our computer screen. At the end of 1 minute, we'll continue to record. This is considered to be the peak of the response. And so in this situation, the patient may feel some dizziness. How are you feeling? Very good. That's completely normal. We fully expect there to be some dizziness with this task. That tells me that the ear is working as it's supposed to, and that we're getting a good response from the ear. And in just a few seconds, I'll turn on a dot to help Sarah come down from that sense of motion. That helps to stabilize the eyes and bring her back to the baseline. And from here, we've reached 2 minutes of recording. Give you a little bit of vision so you can see where you are. And then wait 3 to 5 minutes before we do the other side. Most of the time, we'll start with warm irrigations, just so the temperature slightly above your body temperature. And then we'll move to cool irrigations, just to confirm our results. From there, we create an asymmetry to determine if there's any difference between your ears that can tell us where the problem in your vestibular system may be. This is the most important test that we do in the vestibular lab, and the one that you're most likely going to encounter if you're referred to vestibular testing. On test that
In this examiner used air for this testing, but previously water was using air is better than water because chances of infection is less. Next one is rotational chair assessment. To evaluate the vestibulo-ocular displays or VOR by assessing eye movements in response to controlled rotational movements. Purpose is diagnose vestibular disorders, assess vestibular compensation, differentiate central and peripheral causes of vertigo. This here also, patient is allowed to move in a chair in a dark room, and a chair rotated at various speeds while eye movements are recorded using video or infrared. Ratio of eye velocity to parameters assessed are eye velocity to chair velocity and time in relation between head and eye movements. This symmetry, comparison or response in left and the right direction. Vestibular function is evaluated by this caloric test, and this test monitors recovery after vestibular rehabilitation. Patient is allowed to sit in a chair and allowed to move in a controlled condition.
the rotary chair is just what it sounds like. It's a motorized chair that turns back and forth. The chair is housed in a light-tight booth, so the door is closed. And just like the EMG test, patients will work on and monitor their eye movements. Typically, 1 or 2 things happens in the rotary chair. Either the rotary chair will oscillate back and forth, or the rotary chair will spin in a complete circle for about 45 seconds and stop, and then spin in a complete circle for about 45 seconds in the other direction, and then come to a complete stop. The purpose of the test is to look at how the mechanical center is working. This test is generally done in individuals who cannot have the caloric test done, or who don't tolerate the caloric test, or for young children who are not going to waste their own for water in their ears. The rotary chair test is a typical test of single function for children aged 6 months and up.
So then also, I think you saw the nystagmus in the eyes, and this next one is computerized dynamic posterography or CDP. It is a diagnostic tool evaluating balance and postural control by analyzing visual, vestibular, and somatosensory. So sensory and motor responses are analyzed in the CDP. Visual, vestibular, somatosensory inputs along with the motor inputs are analyzed in this using this computerized dynamic posterography. It is to diagnose balance disorder, whether it is vestibular, neurological, and musculoskeletal. As you know, our balance is depending not only on this vestibular system, this eyes have a role, this musculoskeletal system have a role, then neurological, this cerebellum is also having a role. When they are working together, then only this balance can be maintained. Here, with this test, all except this cerebellum, all of this can be identified with this CD. Then the diagnosed balance disorder and assess both risk in elderly or high risk individuals. I will show the video. The components include sensory test, it is called SOT, motor control test, this is MCT, and adaptation test adjustment to repeated balance disturbance. Identifies whether it is due to sensory or motor deficit, and tailors balance retraining program. And with this test, they can identify whether there is any improvement in balance retraining programs. Objectively measures the fall risk. And I don't know, we have such an equipment in our hospitals, but it is a good idea to do this test. Using the platform will be moving for the sensory system. Yes, you can see that platform is slightly moving. Whether the patient can adjust with that, that's the question. This examiner can adjust the type of movement in the computer. Platform adjustment can be to and fro, side to side, etc. will be moved. In the front there is the sensory system also examines from by seeing the front of the equipment.
Ensuring that dual force plate support surface and visual surround are calibrated. The second step is to position the patient's feet correctly on the support surface and to secure the patient by attaching the safety harness to the safety bar. Next, the sensory organization test and the motor control test are performed. The software automatically computes the patient's score and variables of interest relative to an age-matched data set. The final step is to assist the patient down from the platform and discuss their results. Ultimately, computerized dynamic posturography is used to identify possible deficits in the somatosensory, visual, or vestibular systems, and can also determine if a patient has a visual preference by relying on visual information even when it is inaccurate.
So it is an important system, sensory also. Deficit can be identified with this technique. Next one is vestibular evoked myogenic potential or VEMP. It is also a non-invasive test to evaluate upper lip organs, that is acular and atrial, and vestibular nerve function by measuring reflexes. CVEMP and OVEMP. It is from it assesses acular and inferior vestibular nerve, and ocular, atrial, and superior vestibular nerve can be assessed. The procedure you will see in the video, and the clinical applications diagnoses vestibular disorders, differentiates between central and peripheral vestibular dysfunction, then assess age-related optic lip function. You may be knowing that is optic lips are very important in balancing. So its function must be assessed. This is the equipment for assessing the optic lip function.
Stands for vestibular evoked myogenic potential. And what that means is that we stimulate the ear with a loud sound and then we measure some sort of muscle response in the body. There are typically two nerve responses. We have the cervical band, which is measured at the neck, and then we have the ocular band, which is measured underneath the eyes. The nerve that leads to the vestibular system or inner ear separates into two branches. So we have the top branch and the bottom branch of the nerve. The difference in the bend test is when we measure the cervical band, it's giving us information about the bottom branch of that nerve. When we measure the ocular band, or the band underneath the eyes, that's giving us information about the top branch of that nerve. This is a relatively new test that we do for patients. The advantage of this test is it tells us about how each of the branches of that nerve work, and the test is very easy to do with this not inducing dizziness. Stands for vestibular evoked.
A lot of technologies are available to identify the vestibular function. We usually do only clinical tests, but this much precisely we can identify with these machines. Coming to the next part, this balance mechanics evaluation. Static balance by Tromberg's test. All of you may be doing it regularly, and ask the patient to keep feet together and ask to close the eyes. There is a posterior Tromberg's test, patient will sway. And dynamic balance test also, we used to do weight analysis. For that also, machinery are available just by asking the patient to walk. By analyzing the software, weight differences can be precisely identified. Next one is sensory organization test or modified clinical test of sensory integration of balance. That is also using this type of equipments. We can see that. This is Romberg's test. Ask the patient to keep the feet together. Since the patient is standing well. With eye closure, because this balance is based on the this vision and okay. That's why by asking the patient to close the eyes, he is swaying. This is positive Romberg's test. So that is the modified clinical test of sensory interaction and balance, or MCT SIB protocol. And lot of equipments are available to precisely measure the balance also. What we usually do is clinical examination. Advanced clinical test, that is computerized posterography, as we had seen earlier, and specialized diagnostic test, TICS Halbach maneuver that we used to do in our clinics, especially for Meniere's disease.
This is an example of the Dix fallback maneuver. To begin, we place our hands on the patient's head and rotate their head 45 degrees to one side. Then we wrap the application lay down and extend their head off the edge of their bed so that their head is hanging approximately 30 to 60 degrees in extension. We're going to hold the patient's head in this position and observe their eyes for the presence of nystagmus. This will generally be a rotary vertical nystagmus if positive. We can then return the patient to the upright and seated position and repeat the procedure on the contralateral side.
In this procedure, the examiner should stand on the side of the which side we are rotating the head, and on that side itself, the examiner has to stand at it, see the nystagmus, and then ask the patient about vertigo also. We have to take care of the condition of cervical spine also while we are bending the two side. That also have to take care of. Cognitive screening and hearing loss. Because in hearing loss, there are some problems with the cognition that also we have to think about. The assessment tool of mini mental state examination, MMSE, or Montreal Cognitive Assessment Tool, MOCA, focus areas about memory, executive function, language processing, etc. has to be examined using this tool. And impact of hearing loss, potential cognitive decline risk is there. And annual cognitive screening for hearing impaired patients is necessary to identify the deterioration of the condition and to give better quality of life. We have to this screen yearly and give medications or other procedures. Communication skill assessment, sign language proficiency. Sign language proficiency means we show some pictures and they have to describe that. By seeing that picture, they have to describe that. Literary skill also to be examined. That standardized test is clinical evaluation language fundamentals. Not going to the details. Multimodal communication assessment and individualized communication strategy development must be done for communication skill assessment. Coming to the pathophysiology of this sensory neural hearing loss, the pathogenetic mechanisms include genetic mutations, that is, disruption of key proteins in the cochlear structure and function, restricting the transportation of this sound waves, and ionic dysregulation, impaired ion channel function in cochlear hair cells. Because of this ionic dysregulation, this mechanical sound vibration may not be converted into electrical signals. Mitochondrial dysfunction, reduced energy metabolism in auditory neural pathways, limiting the sound transmission, and oxidative stress, cellular damage to cochlear sensory epithelium and neuronal degeneration. Progressive loss of auditory nerve connections mainly due to aging. Pathophysiological classification include congenital loss, acquired hearing loss, syndromic versus non-syndromic variants. Congenital, genetic mutations disrupting auditory neural pathway development, diagnostic markers, abnormal auditory brain system response testing and genetic screening. Clinical implications include permanent sensory neural hearing impairment or potential cognitive development delays may be seen by evaluating the congenital neurological hearing loss. I can see you all. I can see whether you are enjoying it or you are sleeping. I can see the screen only. It is very difficult to speak in just seeing the screen. As a teacher, it is very difficult. You have to keep the eye contact, then only we will feel comfortable in teaching. It's very difficult. Am I audible? The acute neurological hearing impairment. The pathogenic mechanism include the neurodegeneration, the trauma, inflammation, and vascular. In any disease, we can commonly categorize into 4 categories: degeneration, trauma, inflammation, and vascular compromise. Here also, in acute neurological hearing, also same. These acute categories: infections, autoimmune diseases, metabolic dysfunctions, and finally toxic neural exposure. Ototoxicity we have seen earlier. Then progressive impairment, gradual neural deterioration in chronic diseases, sudden vascular destruction as in autoimmune flare-ups and viral infections, intermittent neural functional loss may be because of this acquired hearing loss. Neurological impact factors, age-related neural changes, this age-related in a family itself, in a younger age itself, this hearing loss can develop. Then systemic disease interactions, metabolic syndrome is a common finding, especially in Kerala. So this may lead to earlier deafness. Then environmental neural stressors can induce this hearing loss earlier day. Medication induced neural modifications. We cannot avoid medication. Aspirin, majority of the persons after this cardiovascular incident, etc., taking aspirin, it is can be a cause of this ototoxicity and finally hearing loss. Then the syndromic versus non-syndromic variants. Syndromic hearing loss, multiple congenital. It is given as a syndrome only. In non-syndromic, it is independent type of hearing loss. This Usher and Waardenburg-Alport syndrome are considered as the syndromes leading to hearing loss. There are associated many conditions along with that in these syndromes. Non-syndromic, only isolated hearing impairment is there. Congenital malformation may not be there. It's primarily genetic or autosomal or autosomal dominant or recessive condition. Most regular clinical management. In syndromic, it is very difficult for diagnosis and management. But here, in non-syndromic hearing loss, it is easy, comparatively easy. And then along with this imaging techniques we are using, now we are moving to this imaging session. Along with this normal imaging techniques we are using, there are some advanced neural imaging facilities available. This CT, MRI, etc. we can use to identify the underlying disease. But that I think everyone knows that. So I am moving on to the advanced neural imaging techniques. There is importance of these because we don't have these machines, but sometimes patients will come with the patient will do all this and come to us with the reports. Then we must be aware that there are some techniques like this. We have to read that report and understand what is in that. That is important, I think. At this point of time, this syllabuses are changing. I think within 4 or 5 years, we have to directly involve in this type of technologies. Advanced neural imaging interpretation. The structure of abnormality can be seen. Functional network analysis can be identified. White matter tract evaluation during the action, which white matter group is involved, that can be identified with these advanced techniques. Then gray matter volume can be assessed with this advanced neural imaging interpretation. Main modalities are functional MRI, diffusion tensor imaging, magnetic resonance spectroscopy, and positron emission tomography are given as the main imaging modalities for this assessing this sensory neural darkness. Functional MRI, brain activation mapping is seen with this functional MRI. It identifies specific neural regions activated during sound stimulation. You see, this is color-coded heat maps to highlight active brain areas. We can see which area, by giving a specific frequency sound, we can see which area is actively or active in that time. with the specific colors, and we see there is no response means sound is not transmitting to that area. That is the inference. Tracks precise neural responses and demonstrate which brain regions responds to different sound frequencies and which are not responsive. The neural pathway visualization, complex neural communication routes can be visualized in this technique. This functional MRI traces signal transmission from auditory receptors to optical processing centers. They reveal white matter tract integrity also. In this functional MRI, auditory cortex functional analysis can be done by evaluating neurological processing mechanisms. It characterizes temporal spatial neural response patterns. It assesses cortical plasticity and functional organization of auditory processor regions can be seen. Connectivity can also be identified with functional MRI. That is intricate neural network interaction can be identified with this functional MRI. This is compensatory neural adaptations also can be seen. This is more video on functional MRI.
Functional magnetic resonance imaging, or fMRI, is a type of neuroimaging used to obtain images of brain activity. fMRI involves exposing the brain to multiple magnetic fields and relies on the observation that protons in the nuclei of hydrogen atoms respond to this procedure by emitting an electromagnetic signal that can be detected by the fMRI scanner. The fMRI scanner is capable of determining some of the properties of the tissue the signal came from and can use this information to reconstruct a high-resolution image of the brain. Additionally, the fMRI scanner can detect differences in the magnetic properties of oxygenated versus deoxygenated blood, and thus can identify changes in levels of oxygenated blood in different regions of the brain using a method called blood oxygen level dependent, or BOLD contrast. BOLD is typically what enables us to identify which brain areas are most active in fMRI. Areas of the brain that are more active tend to receive higher levels of oxygenated blood. Thus, higher levels of oxygenated blood in a particular brain region are believed to correspond to higher neural activity in that region. On a typical fMRI image, color coding is used to represent differences in the level of oxygenated blood, and thus differences in activity. Activity in those areas can then be associated with whatever task was performed at the time of the scan. Functional magnet.
Next is DTI or diffusion tensor imaging. It is used for white matter tract visualization and unit activation. Neural connectivity can be mapped and microstructural neural network analysis can be done. Auditory pathway integrity evaluation is also done with this diffusion tensor imaging. DTI or diffusion tensor imaging. You will see like this only. Very good looking images, isn't it? Then magnetic resonance spectroscopy. With this, biochemical changes can be detected by this magnetic resonance spectroscopy. With this instrument, there are graphs. We will get graph and we have to interpret that. It is a non-invasive neural metabolism study. Without taking a drop of blood, metabolism study can be done with this magnetic resonance spectroscopy. It's a very large topic, and so simple these videos are not available. So sorry, I didn't include one. Positron emission tomography or PET. metabolic brain activity imaging, neuronal function visualization can be done with PET. Everybody may be knowing it is coming common. Glucose metabolism can be mapped and neurochemical interaction analysis can be done with this positron emission tomography.
PET scanner creates 3D images of the body. It does this by using radioactive tracers, which are usually administered to a patient through intravenous injection. The tracers are made up of carrier molecules that are tightly bound into a radioactive atom called an isotope. The carrier molecule can interact with or bind to specific proteins or sugars in the body. The carrier molecule that will be used depends on what the doctor is looking for. To suspect cancer or is monitoring a known cancer's growth, she may use an FT2, a modified form of glucose, which gets absorbed by tissues. When tissues absorb a lot of glucose, these aim to kill a cancerous tumor. The radiation from the tracers poses little danger to the patient since they quickly pass out of the body. The isotope produces smaller particles called positrons, which interact with surrounding electrons. This interaction results in complete annihilation of both particles, releasing two photons that split up in opposite directions. The detectors in the PET scanner measure these photons and use this information to create an image of the distribution of FT2 in the body.
Okay, that is a 60-second time. Very simple videos we can understand what is the idea behind that. And emerging techniques are artificial intelligence integration. Now everybody is using ChatGPT, Copilot, etc. If we can integrate artificial intelligence with the reading of these reports, that will give very precise diagnosis about the condition. So they are integrating artificial intelligence also in this type of neuroimaging techniques. Then computational analysis. I think up to a level artificial intelligence is okay, but above that a human brain must be there to confirm that it is correct. Advanced computational analysis it can be applied in this neuroimaging techniques. Precision imaging techniques. More and more thinner slices can be evaluated using this precision imaging techniques to identify the extent of the pathology. Then machine learning applications. This when we are using an ECG also, they are giving one result. Maybe correct or incorrect, but they can do that. That is a primitive form of this machine learning application. If a well-developed machine learning applications are developed. That is a brief description of this neuroimaging. Next important part is electrophysiological investigations. Mainly four are included. Auditory brainstem response, they are using the children to identify because they cannot convey this level, they cannot identify level of deafness and they cannot convey also in such conditions. This techniques were used. Auditory brainstem response for ABR, emission for AA. Then electrocochleography, the for ECG, electrocochleography is also there. Neural synchrony assessment can also be used as a diagnostic technique. First, ABR, neurological test that evaluate neural pathways from inner ear to brainstem. From inner ear to cochlear nucleus in brainstem, we have to see the response of ABR. It electrical activity is auditory nerve and brainstem in response to sound stimuli.
ABR, or auditory brainstem response, is a test that we use on young children to get a complete hearing test. We do this by attaching electrodes to the forehead and to the ears, and we're picking up the response from the hearing nerve. We put sounds into the ear at different pitches and different levels, and see if we get a response from that hearing nerve, which lets us know if the child is hearing that sound or not.
So in such wavelengths, we can identify this level of hearing loss using such instruments. Otherwise, up to an age, we cannot identify about the deafness in the child. Next one is autoacoustic emissions or OAE. Low-level sounds generated by the cornea, especially the outer ear cells, in response to auditory stimuli can be identified by autoacoustic emissions or OAE. And here also neonatal in children only this is applicable. This in adults also it can be given, but especially it is given for neonates. And then we test for clear outcome health function. So then only this instrument. By seeing the audiogram, this audiologist can identify whether the head cells are responding or not. Electrocopiography is also in vast area. Diagnostic test to measure the electrical potentials area used to diagnose Meniere's disease. And auditory Meniere's disease, you know, that is endoly, there is a problem with the endolymph circulation and resulting in this deafness and this balance problems, vertigo, etc. Arachnoscopy and auditory nerve electrical responses is performed by inserting electrode in tip and membrane. This is one stadium. You have to do this for a lot of time. You have to spare a lot of time to make this video, so I'm skipping that. Coming to advanced methods, high density EEG electroencephalogram, magnetoencephalography, and optical auditory evoked potential have been recent advances in the electrophysiological methods. There another brain computer interfaces because this brain functions can be identified with these computer interfaces. Advanced neuro monitoring and precision neurophysiological mapping are emerging technology. Next is molecular and cellular investigations. Now imaging and electrophysiology is over. This molecular and cellular investigations can also give a light on this causes of this deafness. These studies include, I'm having a brief description I'm planning to give. Protein expression studies. This protein expression in this, if it is proper, not proper, can lead to different types of deafness. Cellular signaling pathway analysis, mitochondrial dysfunction, and neuroinflammation marker assessment. If mitochondria is dysfunction is there, proper energy may not be getting for this nerve cell, and then there will be dysfunction. And if there is cellular signaling pathway is interrupted also, proper functioning in the cell will not be there, leading to different types of deafness. In marker assessment, markers are that much important. If there is we can identify a marker having this indicating the neuroinflammation can be assessed in the earlier stages itself, and the proper treatment can be given in the earlier stages itself. Cellular investigation techniques in immunohistochemistry, gene expression profiling, molecular pathway tracking, and neurotrophic factor analysis. This is some higher level. Immunohistochemistry is applied for identifying the problem with this deafness. Emerging technologies include CRISPR, CRISPR gene editing. That means the pathological area in the gene only are edited for cure of the disease. That is the emerging therapeutic technologies. Majority is syndromic, like we studied, we discussed earlier. The gene which is pathologic, that area only will be removed. That is called a gene editing. Then stem cell regeneration, with this different type of stem cells, whether this purpose can be cured. This many studies are going on that also. That is embryology for this bone marrow stem cells. It is possible to do the incorporate in the treatment of deafness. Studies are going on. Neural interfaces technologies and personalized molecular therapies. The person is having treatment is this coming to personalized therapies. And this personalized molecular therapy can be effective in cases of deafness. Coming to a brief look into these genetic investigations, next generation sequencing. As you can see, genes and the DNA is studies are going on. Chromosomal microarray analysis. These proteins are identified, and this microarray can be analyzed and targeted gene panels, which gene panel is responsible for particular disease. It will be targeted. That such screening techniques are developing. Then specific gene markers are identified. GJB2 or gene mutations. This mutation is responsible for interruption of the sound propagation, and the SLC26A4 gene variations. It disrupts the ionic balance, and the mitochondrial DNA screening is due to this energy level. There are problems with this mitochondrial DNA. Molecular genetic analysis. These are the newer techniques not in this clinical practice, but in later days, this will also be coming into practice. Gene expression profiling, mutation characterization, hereditary pattern identification, etc. Counseling is important in genetic disease. Family risk assessment, consanguineous marriage, etc. may result in risk, and it must be advices must be given to families regarding that. In the reproductive counseling also, predictive genetic testing, because when the offspring may develop such type of genetic disease, we can predict that. Ethical considerations also we have to take care in this era. Clinical management, how will we manage clinically, not into the detail. Then personalized treatment planning. This personalized treatment planning is depending upon the correct, precise diagnosis of the condition, and according to the condition, we have to plan the treatment. Multidisciplinary, collaborative approach. Multidisciplinary means one system, not a system. All systems must be work together to come to a better quality, to give a better quality of life to the patient. In a system, etc., different departments have to work together to get correct diagnosis of the disease. Continuous neurological monitoring. Monitoring is essential for management strategies. Neurology, see, with this regeneration of the neurological cells are very limited. So, continuous monitoring and proper this treatment is essential for at least maintaining the condition. And then rehabilitation. That also, so where they has to do rehabilitation protocol, get a better quality of life to the patient. Future research directions include precision medicine approaches. As we heard earlier, this lock and key mechanism, correct key for a lock. That we have to identify that. Then technological innovation. Technology is for everyone, not only for allopathy patients. We have to adopt that, and we have to make use of that innovations in our system also. If we also have this corrective, this neural degeneration or neural degeneration, if we can identify from a hospital, this patient will also think this, they will correctly identify that. This approach is only. Whether we have better treatment protocol in these neurological conditions than neural persons. Emerging diagnostic paradigms must be identified. When the techniques are developing, we have to read the journals, etc., and update our knowledge. Coming to the conclusion part, comprehensive investigation framework. This much this investigation equipments are available. We have to use it. We have to correctly identify the condition, and we have to take interdisciplinary approach, because I know a patient went to this ANJ doctor and identified that now there is no hearing loss, but you come to me after 6 months, then you may develop hearing loss. At that time, we can prescribe this supportive equipments. But within the 6 months, if they are possible to reverse the pathology, it is Ayurveda can do miracles in their condition. Also, then ongoing research important. A lot of researches are going on. Not in allopathy, Ayurveda also. Our PG students are doing a lot of research in this department. We have to take it into practice, and this is important. Then patient-centric care strategies. Patient is the important person. The personalized medicine we have to develop. You can single drug to everyone. We have to identify the person and then we have to give the care. Thank you. Thank you for patient listening.
Thank you, ma'am. I welcome Dr. VKV Balkrisna sir, Professor and HOD, Department of Shalaki Tantra, Government Ayurvedic College, Kannur, to thank Dr. Priya ma'am for such a valuable and informative session. Sir, please.
ടീച്ചർ എനിക്കൊന്ന് ന്യൂറോളജിയുടെ അഗാധ തലങ്ങളിലേക്ക് പോയി സ്പെഷ്യലിസ്റ്റ് ന്യൂറോളജിക്കൽ എക്സാമിൻ ചെയ്യുന്നതിനേക്കാളും കൂടുതലാണ് ടീച്ചർ പോയിരിക്കുന്നത്. നമ്മളൊരു വേറെ വരെ മാത്രമേ പഠിച്ചിട്ടുണ്ടായിരുന്നുള്ളൂ. പോസിറ്റീവ് ടോമോഗ്രഫി ടോമോഗ്രഫി ഓഡിയോളജിയിൽ നമ്മൾ സാധാരണ യൂസ് ചെയ്യാറില്ല. ടീച്ചർ അത്ര ഡീറ്റെയിൽ ആയിട്ടാണ് പറഞ്ഞിരിക്കുന്നത്. ഐ തിങ്ക് എക്സ്റ്റൻസീവ് നോളജ് ആണ്. സോ താങ്ക് യു ടീച്ചർ. താങ്ക് യു ടീച്ചർ. ടീച്ചറുടെ ആരോഗ്യാവസ്ഥ വളരെ മോശമാണ്. ഇപ്പോൾ ടീച്ചർ ഓൺലൈനിലായിട്ട് ക്ലാസ് എടുത്തതിന് സഹായിക്കേണ്ട ഡിപ്പാർട്ട്മെന്റ് വേണ്ടി എൻ്റെ ഹൃദയംഗമായ നന്ദി ഞാൻ രേഖപ്പെടുത്തിക്കൊള്ളുന്നു ടീച്ചറെ. താങ്ക് യു. സംശയങ്ങളുണ്ടെങ്കിൽ ചോദിക്കാം. ടീച്ചറെ
The session is open for discussions. Delegates, those who are having doubts, they can write down the queries in the paper which will be provided to you. I repeat, delegates who are having any queries can write down the queries in the paper which will be provided to you.
ഇവിടെ വന്ന് ചെയ്യാൻ പറ്റാത്തതിന്റെ നല്ല സങ്കടമുണ്ട്. കുറച്ച് ഹെൽത്ത് ഇഷ്യൂസ് ഉള്ളതുകൊണ്ട് അപ്രതീക്ഷിതമായിട്ട് വരാൻ കഴിയാതെ പോയതാ. അല്ലെങ്കിൽ വന്ന് കണ്ട് ചെയ്യുന്ന ഒരു സുഖം ഓൺലൈനിൽ ഒരിക്കലും വരത്തില്ല.
I hope there's no queries. So thank you, ma'am. So that was a very valuable and also informative session.
Thank you. ഒരുപാട് സന്തോഷം. എനിക്ക് ഒരു ചാൻസ് തന്നല്ല സാർ. ഓഫ്ലൈൻ ആണെങ്കിൽ ഓൺലൈൻ ആയിരുന്നെങ്കിൽ ലീവ് ചെയ്യാലോ.
താങ്ക് യു.
സാർ എനിക്ക് ഞാൻ ലോഗ് ഔട്ട് ആവട്ടെ. താങ്ക് യു.
We'll be having the next section after 5 minutes after having a tea break. Next, we have a session on Ayurvedic Management of Hearing Loss, Insights and Case Discussion by Dr. VKV Balakrishnan Sir, Professor and HOD, Department of Shalaki Tandra, Government Ayurvedic College, Kannur. It's our pleasure to introduce Dr. VKV Balakrishnan Sir, a distinguished academician and clinician in the field of Ayurveda. Sir has completed BMS from VPSB Ayurveda College, earning gold medals in every academic year. Sir further demonstrated excellence by securing first rank in postgraduate studies. Sir has served as faculty at Ayurveda Ayurveda College for 3 years. Sir has also secured first rank in Kerala PC Medical Officer exam. A renowned presenter, he has shared his experience at various international and national forums. Currently, Sir serves as Professor and HOD in Shalaki Tandra Department, Government Ayurvedic College, Kannur. We are honored to have him lead our academic endeavors and share his vast knowledge with us. So once again, I invite Dr. VKV Balakrishnan Sir for his session. Sir, please.
Thank you for a good introduction. Dear delegates, my dear colleagues, my friends, welcome you to my session. Being the last session, don't sleep at all. I won't make you to sleep. Okay. I want you live. Okay. Actually, I think usually afternoon, no? After the heavy lunch, we sleep always. Especially when the Rutu is changing. So I think somebody is sleeping. So I won't make you to sleep. You have to listen. Okay. It's not a one-sided oriented presentation. It will be two-sided. I need questions from you, and I'm ready to answer for your questions. And not only the theory I want to share with you. I want to share certain of my clinical experience which I have came across in my career in this college. Since 19 years, I'm working here. I'm working predominantly for eye, I think, but occasionally I work in for ENT also. So predominant case is I know that ophthalmology. Shalaki is comprising always ophthalmology, not even I think dentistry and ENT. But it's also there. Anyway, the NCSM is planning to divide the department into various entities in the coming year. Maybe one ophthalmology and one KNP, Karnanasa Kantaroga, and one more dentistry, I think. Very recently, it may divide and you, the PG colleagues may get the opportunity as being a faculty very recently, I think. Okay, anyway, I'll go to my session. Welcome all of you. So I'm going to tell only few things related to bacteria. As we know that it is a essential disorder in the language. Everybody know that, isn't it? Even ourselves. But it won't be in the criteria of treatment. As we decided that already that they are going to be lied down. Where we have to give caution and precaution to the kids when it happens. So I think it is not pediatric. So be careful related when we are came across in the pediatric cases, especially those who are working in dispensaries. Okay. So maybe we may see plenty of kids with some or other problem with the ear. They may have come with ear discharge, may come with a earache, somebody may come with hearing loss. You have to differentiate it thoroughly. You have to examine. You need only a torch, a small tuning fork, nothing less. That is sufficient to assess the clinical evaluation of hearing loss. And again, identify the cause, treat for the cause. Don't pour any oils or any fluids to the ear at any cost. If you don't know the case, kindly avoid as much of Karnapurana. Okay, it may result very haphazard. Very badly, it may result the hearing. And if you don't know the case. So in a text it is here and there it is mentioned to do Karnapurana. But Acharya specifically mentioned, especially when he explains about
कर्णस्राव चिकित्सा पक्वे पुयवगे कर्णे धूम गड्डूष नावन युज्या नाड़ी निधान दुष्ट व्रणहरं चये द्वौ कालु पिजिवर्तुबि पुरेण दुबयित्वानु माशिकेन प्रभोरे. It will be cleaned the ear twice or thrice or more than 2 times in a year. Dhuma is a first. He told to put only fumigation. Purena dubaitwanu, you fill or fumigate with the gugulu or any antibacterial drug. Machigena prabhure, you fill the ear if it is the only with the makshiga or a viscous fluid, not a liquid or a watery fluid, only with a viscous hand. So yes, it never enters in the external auditory canal or in the middle meatus. Never it enters as it is highly viscous. And we have to wipe it off. Shula kleda nivartana vidiresha pravartaka. You have to do all these things when there is it ends the shula and kleda. Or otherwise you are not supposed to put any eyes or any virus. Some virus I read in a new magazine. Some doctor has wrote to put to Madhavu Teresa and Tilataila in the yeah. So many comments I read. Actually, I think that person was not knowing what explanation is given in the text. Actually, it is actually very bad to us. You see, I have read in Ayurvedic Management or Madhurumi or somewhere else. So should not write such nonsense. Be study well, assess well, then you comment on our text. Don't go Madhurimi Teresa and etc. there. Madhurimi Teresa is when he told when there is fungal origin it is there. Sratra Randu Yanajade, when there is fungus is there, you pour mother that is acidic in pH which destroys the fungus. Nowhere is he told to pour Madhulungiresha. Then Ayurvedic Management came that whenever there is pain in the ear, you pour Madhulungiresha and some nonsense. And so in the comment, these type of nonsense things are going on in Ayurveda, isn't it? I think at least Malika remembering. So should not blame our text, okay? Our text they are written after plenty of observations, not 1 or 2. Even today I told just to my student, how many times he might have observed that before writing the word. How many times he might have observed in each and every sentence. Simply he has not written. After repeated observation, he has written the textbook. And maybe that people will be speaking in local language, but Acharya wrote in Sanskrit language. Forever knowledge. Is it so? So, lack of knowledge usually results in blaming of ourselves. Even when Acharya told, don't give medicine in certain areas. Okay, Chalakendra, when we are taking across in the certain area, we can see that don't give any medicine orally. You do external therapy. Majority of our physiotherapy therapies are external, not internal therapy, except Vasti. Majority of therapy are external therapy. Even Vasti, the Aushadha will come back as such. Even in Vamana, it will come back as such. Isn't it? It won't stay there. Unless Snehapana. Snehapana will go into straight. When Snehapana is not a simple drug, which is prepared after boiling. You see, where we have to reduce the water content as such, as there is no signs of any bacteria inside, and it is purely a medicine which is derived from the milk, from the butter, from the ghee, prepared with the medicines. So possible contamination is not there, nowhere else is there in our medicines. When we are using in some other way, it affects very badly. Is it so? So Badri is a slow progressing disorder according to Ayurveda. It's not coming as a single day. Badirato Kramena Cha. Sleshmana Nivado Vado, Nado Vasamubechitaha, Uchehi, Kutra Sundi, Kulia, Badirato Kramena Cha. As it's a slow growing or processing or progressive disorder. It not comes as one or a single day. In that time, as major trauma was less in that time, there was no vehicles, there was no motor vehicle accidents. Then nowadays, and there was no viral infection much. Now it is the sudden also hearing is there. That time it was very, very less. Then if it can come with other associated disease, that is Sleshmana and Nugado Vado. The Sleshmana refers various other sort of diseases where metabolism is slow. You know that Kapha always slow the metabolism, but Pitta increases the metabolism. Due to causes of ear itself or pathological causes. Due to the cause of ear itself, it can has as hearing loss, or due to the other causes, otological causes and non-otological causes. We divided in such a way that even today it is the same classification, there is no difference. Then improper management. If the treatment is not done properly, or if it is done wrongly, it results in hearing loss. One example I will tell. when we are giving antibiotic for certain diseases. You say streptomycin for a long-standing cough. Now nowadays streptomycin is there. Instead of that, ceftriaxone is there, or cefixime is there, or amikacin is there, or deltamycin is there. If it is given in the within 1 year of a life of a child, he will become deaf due to ototoxicity. I am handling here showing the case majority of only with ototoxicity which created a child as deaf and dumb. I think 4 or 5 cases are there. Only with ototoxicity I treated well. We treated in our department, got back the hearing, and they survived their life as normal child. Only because of ototoxicity. So I will discuss about it. Okay. So management. Only one small sentence I told them regarding Samprati. My topic is management and clinical experiences. Management based on the cause. Nidana Parivartana Chikitsa. Okay. Or Samprati Vikarana Neva Chikitsa. If the cause is maintaining we have to stop it. Just like water is not there in the tank, known to put the switch the motor, kindly identify where the leak is there. Identify the leak and seal the leak, then fill the tank. Otherwise, it will never end. You know that. So, remove the cause. If the cause is due to the garage or the smartphone, or earbuds or anything, you have to remove first of all. Otherwise, never it ends in. There is no meaning of treating them. Those who are keeping both sides with, maybe on 1 or 2 hours, not on put a whole night. The people will put their and they will sleep. You see that the whole time our tympanic membrane, our vesicular chain, and ventral vestibular, and the scala media, and rectus membrane, and inner hair cells, and outer hair cells, and cerebral aqueduct, and auditory nerve is working continuously throughout the night. What will happen if it continues for many days? Definitely it will get destroyed, no doubt. And then a result is hearing loss. And for that treatment is whether it's needed or not. First we have to do, you have to remove that one. I used to tell to the kids, especially those who are in adolescent and growing age, kindly avoid this type of instruments keeping in the ear beyond, especially during night time. When we are sleeping, we have to give rest for our sensory organs also. Okay. So, congenital causes. Congenital cause usually comes in maternal infections as maternal rubella. You may have heard the test of TORCH. TORCH is a test which is conducting to identify the viral load of a mother or a lady. Toxoplasmosis, rubella, cytomegalovirus, and herpes simplex virus. Those who are positive with rubella and cytomegalovirus, especially rubella, if they are getting carried, their offspring may have with congenital hearing loss. So just now we admitted a case Ivan having maternal rubella. Just now I admitted. Okay. And he's about 1.5 years old. There is no signs of hearing. So giving medicine for the kid. Whether it is applicable to give medicine for the kid, if the maternal rubella is positive, we have to treat the mother first. According to Ayurveda, Kshiradha, Annada, and Annada, isn't it? Kshiradha, Kshira, Annada, and Annada. So the mother is rubella lineage positive, feeding to the baby, and baby is having hearing loss. Still, so far it is not identified. Just taken a Bera. That's what just now great teacher told what is Bera, and responses of hearing responses. It is nil. That guy is just walking here and there, but he is not listening. He is not responding to any voice. The main problem is that when there is no hearing, automatically the kid become mute. That's the real thing. IBM only used to see the things, where here we use for hearing, talking, and even our maintenance of balance. We lose 3 functions at a single time. So, if there is maternal rubella, the disease which comes as from rubella, that is congenital hearing loss, usually the progress is very, very bad. But if it is within 3 years, by using therapy of our system, and again with speech therapy along with, and monitoring in a higher center, just like hearing, speech and hearing institute, just like Manasa Gangotri at Mysore, we can manage the case simply, and the baby may have hearing and speech at the age of 10. Maybe not correct, but he will develop the speech center and hearing center. We have to try for it, or otherwise we have to refer to major surgery for cochlear implant. Should not keep the baby beyond a time. If the cochlea is okay, possibility of hearing is there. that we can assess within few days of treatment. If it is the case of maternal rubella, it's a congenital hearing loss. Second one is ototoxicity, which is very, very common nowadays. That's right, especially when the kid is getting any gastroenteritis or any viral fever if he is admitted to the hospital. They may put an antibiotic just like amikacin or gentamicin or ceftriaxone or ceftriaxone or sulfaxine or any third derivative antibiotics. Definitely, it results in at least 7 to 9% of the kid developing ototoxicity. Hearing capacity will be reduced. Their speech will be reduced afterwards. So here we are treating majority of these with the ototoxicity. So we'll come to that. Then otological causes. Includes ASOL. I think everybody knows that ASOL and COL and otosclerosis